You have a patient panel. You are responsible for them, but you are likely losing money on them right now. This leak happens every time a patient on your panel misses a preventive screening or a chronic care test. That space between a screening a patient was scheduled to receive, like a colonoscopy or a diabetic A1C test, and what actually happened, that is a care gap. The healthcare industry tracks this through HEDIS, a measurement system of over 90 distinct quality metrics. It functions essentially as a list of yes or no questions, asking if a patient received the required intervention during the measurement year. Every time the answer is no, your clinic logs a failure. Accumulate enough of those failures, and your star ratings and quality scores take a direct hit. This visualization maps out the $15 billion Medicare Advantage bonus fund. Notice how portions of that capital actively drain away. That represents the financial penalty of these missed measures at the national plan level. Those plan-level losses flow downstream quickly. They dictate the financial terms of your network negotiations and shrink the shared savings pools for individual primary care practices. Every unreturned phone call about a mammogram functions as a mechanism that actively erodes your practice's revenue within your value-based contracts. Let's bring those billions down to the scale of your specific clinic. This chart breaks down a 200-patient panel. Following that declining line, a practice loses up to $150,000 annually in HEDIS penalties due to unclosed gaps. The heaviest drops come from missed colonoscopies, mammographies, and A1C tests, which carry severe financial penalties. And the pressure is increasing. CMS published their 2026 Medicare Physician Fee Schedule, introducing rule changes that prioritize primary care. That CMS shift explicitly ties your future reimbursements even tighter to how well you execute chronic disease management and preventive screenings. Delaying a systematic strategy for closing these gaps guarantees your profit margins will shrink in the coming years. Many practice owners assume closing gaps means having staff dial numbers when the front desk is quiet. But look closely at the required effort. Here is a flowchart mapping the true process. Before a patient is even contacted, your staff has to pull the EHR report, cross-reference payer attribution, and check pre-authorization requirements. Then they hit the outreach phase. The bottleneck here is massive. Nearly 70%. You pay a financial penalty for a screening that the patient actually received, simply because it wasn't formatted correctly in the EHR. Looking at all these steps, it's clear this workflow is a specialized administrative data engineering challenge that requires dedicated oversight. Despite the administrative nature of this work, the default strategy for most clinics is reactive, handing a list of names to existing clinical nurses and medical assistants to handle between rooming patients. This line graph plots the cost of that decision. Over the last decade, clinical triage nursing wages have grown by over 84%. With median RN compensation now approaching $80,000, and that premium clinical time is being drained. Right now, fragmented outreach consumes 8 to 12 hours of nursing time per week per provider. When clinics try to solve this by hiring someone specifically for these repetitive calls, burnout takes over. Staff typically quit within 12 to 18 months, forcing you to restart the recruiting and training cycle. Using your premium clinical staff to chase down lab results and navigate payer portals creates a negative return on investment. There is a practical alternative to managing this internally. Growing numbers of value-based groups are transitioning this exact workflow to a dedicated, outsourced virtual staffing model through Staffingly. Instead of burdening an overwhelmed physical clinic, the work shifts to a specialized virtual environment designed entirely for administrative execution and precise follow-up. Staffingly utilizes dedicated, permanent teams rather than a shared pool of rotating agents. This ensures the staff builds real familiarity with your specific clinical protocols and patient population. An AI prediction engine analyzes EHR data streams to flag approaching screening intervals. A prioritization layer then ranks those gaps, pushing high-value tasks like colonoscopies to the top. During outreach, a barrier detection system instantly generates tailored alternative routes to bypass patient hesitations. Ad hoc manual calls fail because they rely purely on repetition. This dedicated infrastructure succeeds because it uses predictive data to engage hesitant patients intelligently. The choice comes down to an objective financial comparison between attempting to maintain control in-house versus outsourcing to specialized teams. This comparison matrix outlines the math. On the left, the fully loaded cost of an internal hire totals $60,800. On the right, the Staffingly model is $21,600. That is a 64% cost reduction, saving nearly $40,000 annually per position. The expected performance outcome is equally concrete. Practices typically see a 10 to 20% improvement in actual HEDIS closure rates within their first 60 days. And this model operates securely inside enterprise-grade compliance frameworks, carrying SOC 2 Type 2 and HITRUST certifications. Getting started is low risk. Go live takes 48 to 72 hours, backed by a risk-free pilot. You are already responsible for these patients. Stop subsidizing administrative inefficiency with clinical wages and adopt a specialized model to protect your value-based revenue today.